So to return to this question, a person with a follicular lymphoma often can have that follicular lymphoma very effectively treated with radiation or chemotherapy and immunotherapy, treatment with a monoclonal antibody along with their chemotherapy. And many patients have their disease suppressed very thoroughly that way. I have patients coming to see me who first saw me 30 years ago with their follicular lymphoma. And although they still have their follicular lymphoma, we've been able to keep it suppressed and under control for 3 decades now, and they're doing just fine. But sometimes that doesn't work. Sometimes the follicular lymphoma is resistant to those treatments, and despite their best use, it comes back and it threatens the person and makes them sick and might even threaten their life. And under those circumstances, it is sensible to consider using very intensive treatment with potentially great toxicity to it in an attempt to control the disease because no other alternatives are available. And that's the circumstance in which one might use very high-dose chemotherapy and help the person get over the side effects of the high-dose chemotherapy by giving them these transplanted cells. If allogeneic transplant is used and proper suppressant medication comes along with it, then a person does tolerate the transplanted cells and they don't attack them and cause graft versus host disease. And the high-dose treatment that they received may well have been able to get rid of the lymphoma. And so there is a chance that if all works out as we might hope, that they can be cured by the high dose of the chemotherapy and spared from any severe or bad side effects from the transplanted cells. And in fact, there's even a possibility that these transplanted cells that are put in will help out. They'll participate in the eradication, the curing of the target disease, the follicular lymphoma. Because if everything works perfectly, these new cells may recognize the follicular lymphoma cells as ones that are undesirable and actually mount an immune attack on those cells. And you saw that picture I showed of those T cells that could grapple with the malignant cell and actually kill it off. So the hope would be that the transplanted T cells that have been put in will actually attack the lymphoma cells and contribute to the likelihood that the disease will be cured. And that's called graft versus lymphoma effect, or graft versus disease effect. So the ideal is to minimize the graft versus host, minimize the likelihood of rejection, maximize the graft versus disease effect, and also get the benefit of the high-dose chemotherapy that was given before it. And you can see you've got a very complicated situation. But every once in a while, that is clearly the right technique to use for treating a person, and occasionally is capable of curing the follicular lymphoma and justifying all of the cost, toxicity, and potentially bad effects that may result from trying to employ that kind of a technique. What is my comment on the future for lymphoma treatment? Well, I guess the best way I know of to predict the future, which is what this person is asking me to do, is to think about the past. So it's not always true, but generally the way things behave in the future is the way they have behaved in the past. So I think back to what's happened over the nearly 30 years that I've been looking after patients with lymphoid cancers, and currently there are a whole collection of tools and treatments and ways of thinking about these diseases and treating them that simply weren't available when I started out those 30 years ago. So a couple of examples. 30 years ago, when I treated a person with multiple myeloma, another lymphoid cancer that we haven't spoken about very much today, the average patient lived about 3 years. Today, the average patient lives 7 to 10 years because we have new effective medications and better ways of using the treatments that we already had present that we've figured out, so we can take better care of that person today. We have new medicines. One of them is a thing called a monoclonal antibody. It's one of those manufactured antibodies. This is a medicine called Rituximab, and we didn't have that to treat lymphomas before about a decade ago, and since then we've learned a whole lot about how to use it. So 10 to 15 years ago, when a person came to me with a large cell lymphoma, or diffuse large B-cell lymphoma, that's the most common single kind of lymphoma that people can develop, I would have had to tell them that on average, about half of the people with this disease who come to see me die from the disease. Today, I can tell those same people that 75% of the people who come to see me live with this disease. Only 25% die from it. So we've made things very much better by discovering a new medication and then figuring out how best to use it. The thing that encourages me to hope that improvements will come in the future, even perhaps a little faster than 30 years, which is a long time to wait for things to get better, is the explosion in understanding these diseases at a fundamental level. So I didn't concentrate on it very much, but the techniques that can be used scientifically to come to understand lymphoma cells better that are available today are remarkably better than they were just 5 years ago. So I'll give you a single example to help you get your mind around that. How many of you have ever heard of a thing called the Human Genome Project or the Human Genome Atlas or whatever? I see heads nodding. This was an attempt to take cells from an individual person and actually check and count up every single chemical structure in the entire collection of DNA in all the chromosomes. How big a task that is can be, I guess, made an example. If you think of, this was just like a code with 3 billion items in the code, a long string of letters that had to be decoded. And the project was to figure out what was the entire string, read the alphabetical characters of the entire 3 billion signals in the DNA. Well, it cost somewhere around $3 billion to do that the first time, to figure out the genetic sequence of the chemicals in the DNA of one person's cells. Today, it's likely that within the next year, we'll be able to accomplish exactly the same thing, that is, count every one of the letters in the coded alphabet, the whole 3 billion of them, in cancer cells or in individual cells for about $1,000. So what cost 5 to 10 years ago $3 billion to do, we should be able by the end of this year to do for $1,000. If we can actually decode the structure of lymphoid cancer cells at that level of detail, we are a whole lot further along towards understanding what it is that's really wrong with them, why they behave the way they do, how they got that way, and most importantly, what we can do to manipulate them and either make them go away or make them behave better. So I'm encouraged to think that the future holds the potential for identifying new and better treatments at a faster rate than we have in the past. And so I think the improvements that we've seen over the last 30 years, which have been substantial, perhaps will accelerate and we'll be even able to accomplish a better outcome for these people in the near future.